Welcome to Pulse&Pressors, where critical care gets crystal clear. Succinylcholine remains the fastest-acting neuromuscular blocker in airway management. Its rapid onset, short duration, and unique depolarizing mechanism make it a powerful tool in the right patient and highly dangerous in the wrong one. This masterclass reviews its pharmacology, risks, and expert-level considerations. Succinylcholine binds nicotinic acetylcholine receptors and initially behaves like acetylcholine. The receptor stays open, causing constant depolarization of the muscle membrane. Fasciculations occur first, followed by flaccid paralysis. Because succinylcholine is not broken down by acetylcholinesterase, paralysis continues until the drug diffuses away. Its onset is 30 to 60 seconds, making it the fastest paralytic available. Duration is only 5 to 10 minutes. Plasma cholinesterase rapidly metabolizes it, but deficiencies prolong paralysis significantly. Patients with myopathies or genetic variants can experience prolonged apnea. Succinylcholine raises serum potassium by up to 1 milliequivalent per liter. This rise is small in healthy patients, but becomes lethal in states of nicotinic receptor upregulation. Burns, crush injuries, denervation, immobilization, and neuromuscular disorders all create a potassium surge that can cause cardiac arrest. Contraindications revolve around conditions that amplify potassium release or alter receptor physiology. Burns after 24 hours, crush injury after 24 to 48 hours, spinal cord injury, neuromuscular disorders, and myopathies make succinylcholine unsafe. Severe hyperkalemia and metabolic acidosis further increase risk. Succinylcholine is a known trigger of malignant hyperthermia through overactivation of the RYR1 receptor on skeletal muscle. This leads to uncontrolled calcium release and a life-threatening hypermetabolic state. Dantrolene is the antidote. This topic will be covered fully in your separate MH masterclass. Fasciculations are normal and often frightening to watch. They do not reliably prevent rises in intracranial pressure. Pretreatment with non-depolarizing agents does not consistently reduce this effect and carries no proven clinical benefit. Concerns about intragastric pressure have also not translated into real-world aspiration risk. RSI doses range from 1.0 to 1.5 milligrams per kilogram. Higher doses are needed in infants and young children due to their greater volume of distribution. Repeat dosing should be avoided because cumulative effects produce prolonged paralysis. Elderly and cachectic patients require lower doses. Succinylcholine's greatest advantage is speed. Rocuronium can match the onset only at high doses and at the cost of prolonged duration. Succinylcholine is useful when brief paralysis is needed and physiology is stable. Rocuronium is superior when disease states increase succinylcholine risk. Patients with Pseudocholinesterase variants metabolize succinylcholine slowly. Pregnancy, liver failure, and massive transfusion reduce enzyme activity and prolong paralysis. These patients may remain apneic long after expected recovery. Organophosphate poisoning, magnesium, and certain medications delay succinylcholine breakdown, increasing paralysis duration. Chronic anticonvulsant use may reduce sensitivity, requiring higher doses. These interactions are clinically important in both intensive care unit and emergency settings. Succinylcholine is ideal when airway control needs to be achieved rapidly and the patient has stable physiology. Elective RSI in the operating room or emergency intubations in low-risk patients are the ideal settings. When potassium is normal and there is no receptor upregulation, its speed and short duration shine. High-risk scenarios include sepsis, burns, neuromuscular disease, crush injuries, stroke, and metabolic acidosis. These conditions amplify potassium release or alter receptor expression, making succinylcholine potentially lethal. Succinylcholine is unmatched in onset and brevity, but its risks demand deep physiologic understanding. When used properly in healthy or low-risk patients, it is an outstanding RSI drug. When used incorrectly, it is one of the most dangerous medications in critical care. Rocuronium remains the safer option in complex or unstable physiology. This is Pulse&Pressors, reflecting on the marvels of the human body. Subscribe to stay sharp.